I am going to be talking, in some ways, maybe about a different version of the ketogenic diet than some of you are familiar with, because low-carb diets have been used for a couple hundred years for treatment of obesity and the treatment of diabetes. But the ketogenic diet in particular is a special diet that was specifically formulated for the treatment of a brain disorder. So I have no disclosures whatsoever. The research that I do, I don't get paid a penny for. This is all a labor of love. So I'll do a quick overview of what I'm going to talk about. What is the ketogenic diet? I'll fly through some of that because you all know it. I'll give you the story about the ketogenic diet and its use in epilepsy, tell you a little bit about how this diet works. We'll talk about the ketogenic diet and its use for neurological and psychiatric conditions. I'll talk a little bit about the connection between what we call mental disorders and what we call metabolism or metabolic disorders. And I'll end with implementing this intervention in psychiatric patients. So what is a ketogenic diet? This is the one I'll fly through. You all know this. A diet that's high in fat, low in carbohydrate, moderate in protein. It was developed in the 1920s specifically by a physician for the treatment of epilepsy. I'm going to assume you all know about ketones, beta-hydroxybutyrate, acetoacetate, and acetone. The biggest thing, I'll point your attention to the bottom bullet. Some people think ketogenic diet, you have to lose weight. Absolutely not. This diet was developed specifically for children with epilepsy, children who are growing. This diet absolutely can result in normal, healthy tissue growth, and that means weight gain. And so you can absolutely gain weight on a ketogenic diet. And so some people, when they choose to do the ketogenic diet for weight loss, and they're in ketosis, their ketones are high, they can absolutely gain weight on this diet. So that brings me to the next point. There are different variations of this diet with different physiological effects. And we do not have evidence whatsoever that these are all interchangeable. They might be. And depending on the person, they could be. But I'll walk you through some of these variations of the ketogenic diet. So the classic ketogenic diet, developed in the 1920s, is usually referred to as a 4-to-1 or a 3-to-1 ratio diet. And what does that mean? It means 4 grams of fat for every 1 gram of everything else. Fat has more calories than protein and carbohydrate, and so a 4-to-1 ratio or a 3-to-1 ratio diet basically means that 80 to 90+% of your calories are coming from fat. There's fasting and intermittent fasting because this diet mimics the fasting state, and so you can certainly intersperse fasting and intermittent fasting to get a therapeutic effect. There's the MCT ketogenic diet, adding medium-chain triglycerides, which are more easily converted into ketones, can result in higher levels of ketosis with a lower ratio. So you might be able to go to a 4-to-1 to a 3-to-1 ratio diet if you add MCT oil. There's the Atkins diet and the LCHF diet, which most of you are familiar with, usually used for weight loss or diabetes. There's the modified Atkins diet, which is actually an evidence-based treatment for epilepsy. The modification is to add more fat. So you do the Atkins diet, think about the traditional Atkins diet, and this is the diet where you are, in fact, going to add fat every opportunity you have. Add butter, add olive oil, add fat bombs. You're constantly adding fat. In general, the modified Atkins diet results in about a 2-to-1 ratio diet for most people, just implementing it in a kind of non-rigorous way. There's the ketogenic diet, calorie-restricted diet. So we've heard about the ketogenic diet for weight loss, or for cancer treatment. And Dr. Seyfried published one case report in a human of somebody's cancer going into remission. When she stopped the diet, the cancer came back and she passed away. But I want to just be clear, the diet she was on was a 4-to-1 ratio ketogenic diet. I'm going to show you what that looks like. And she was calorie restricted to 600 calories a day. That is not the keto that most of you are doing. The There are ketone supplements, and then there are websites and books and self-proclaimed experts who say, keto, I know about keto, I'll cure your cancer. Keto, I know about keto, I'll cure your schizophrenia. Please be skeptical of those claims. So a lot of people in the keto community don't really know this literature and don't know these concepts. So this is taken from the Charlie Foundation, and it is a great pictorial. What you see before you are 4 different meals, and they all contain the same ingredients, and they are the same number of calories, 400 calories per meal. I'll call your attention to the green plate. So the green plate, all of the meals have chicken breast, broccoli, mayonnaise, and olive oil. And the green plate is what most people would think of as a standard kind of low-carb, maybe even keto diet. So you've got a decent serving of chicken breast, a decent serving of broccoli, and you've got a ramekin of mayonnaise that needs to be consumed, and then you've got a splash of olive oil somewhere on that plate. If you look up at the red plate, again, same number of calories, same ingredients, you get a tiny portion of chicken breast, a very paltry portion of broccoli. If you're going to eat broccoli, most people eat more than that. You've still got your ramekin of mayonnaise, and then you've got a syringe of olive oil. And all of the olive oil and the mayonnaise need to be consumed. The syringe of olive oil is great because it represents that this is not a weight loss diet. This is a medical prescription diet. It should be prescribed by a physician or clinician, and it should be monitored for safety. And you're doing this as a treatment for a serious medical disorder. This is not a weight loss diet. So let me tell you the story about the ketogenic diet and epilepsy. So it turns out that this all started with this observation that fasting can stop seizures. So this has been known since the time of Hippocrates, that if somebody was seizing in the old days, the one most effective intervention was to have them go without food. Starve them, fast them, do a therapeutic fast. For a long time, as Western medicine evolved, for a long time this was just thought to be religious folklore, because religious attribution was always the reason why the seizures stopped. God likes fasting. We are going to make a sacrifice. This person is going to fast, and the seizures will stop. It might have been even interpreted that the seizures represented demon possession. This person is possessed by a demon, and the way to get rid of it is to make a sacrifice to God and fast him, and his seizures will stop. So Western medicine thought this was just a bunch of bunk. That's crazy. God doesn't heal when you pray to him. So that's not rigorous at all. And in 1921, Dr. Galen reported the use of actually using intermittent fasting to treat a child with epilepsy and said, actually, no, this actually works. It's actually more than just religious folklore. That same year, it was the ingenious Dr. Russell Wilder who solved a conundrum. You can only fast people for so long. And then guess what? They'd starve to death and die. And usually, when you have the person start eating a diet again, the seizures come right back. So it's a great short-term intervention, but not a very good long-term treatment plan. So Dr. Russell Wilder created the ketogenic diet specifically to mimic the fasting state. He thought if we just give them a lot of fat, maybe the body will think somehow that it's taking those fat stores from your own body and that it's really mimicking the fasting state, and maybe we'll get the same therapeutic effect. And in fact, he was correct. Early results were pretty impressive. 50% of patients were seizure-free and another 35% were markedly improved. You notice this is not 100%. It does not work for 100% of people. It fell out of favor by 1950 with the advent of anti-seizure medications because there is no question this diet is really difficult to do compared to popping a pill every day. But it was rediscovered in the 1970s at Johns Hopkins because lo and behold, 30% of our current treatments, this is even to this day, 30% of our treatments don't work for people with epilepsy. People can seize despite numerous medication trials, despite brain surgery, despite electrode implants and other things. They can still continue to seize, even with the best treatments we have to offer. And the resurgence of the ketogenic diet and its use in epilepsy really should be attributed to Jim Abrams and the Charlie Foundation. I can tell you that story in the Q&A if you want to hear it. But due to him and his efforts and his advocacy, we now have over 500 ketogenic diet centers around the world. There was a Cochrane review, which for those of you who don't know is kind of the gold standard of a meta-analysis in the medical field. Cochrane review included 7 randomized controlled trials in over 400 children. And at 3 months, seizure freedom rates were as high as 55%. Another 30% had a 50% or greater improvement in seizures. Again, doesn't reach 100%. But I want to point out, these are treatment-resistant epilepsy patients. They've already tried numerous medications and or brain surgery, and it hasn't worked. The modified Atkins diet was not found to be as effective as a 4-to-1 ratio diet. So this is where the different diets may play a different role. And in Freeman et al., if you look at all comers, at 1 year of all of these pediatric epilepsy patients who are coming to a clinic, 55% of them remained on the diet after 1 year because it was clearly doing something beneficial. 45% discontinued it either because they couldn't do it or it didn't work. So how does a diet stop seizures? So we actually know more about the effects of the ketogenic diet on the brain than we do any other dietary intervention, hands down. That includes omega-3 fatty acids. That includes Mediterranean diet, vegan diet, vegetarian diet. Take your pick. Vitamin B12 even. Take your pick. Any dietary intervention, we know more about the effects of the ketogenic diet on the brain than any other dietary intervention. Why is that? Because this is an evidence-based treatment for epilepsy that works when other treatments fail to work. Neuroscientists, neurologists, and biotech companies have been studying this diet for decades, looking for new targets. What is this diet doing? How is it working? Maybe we can develop a new med based on this diet. So we know a lot. I have simplified this diagram, and I'm not going to go through the hundreds of articles that support all of this evidence, and instead I've boiled it down to simple concepts that you can understand. But please understand, I didn't make these bullets up. These are all supported by innumerable studies that I'm not citing for you. But it lowers blood sugar and insulin. You all know that already. It produces ketone bodies, which are an alternate source of energy instead of glucose. And glucose hypometabolism has been found in a lot of brain cells. And that means the brain cells often cannot use glucose as an energy source, and ketones can kind of get into brain cells much more easily than glucose. Ketone bodies are an important signaling molecule. They are more than just an energy source. They actually result in a whole cascade of effects, including epigenetic changes, including all sorts of things, metabolic changes. Ketone bodies themselves have an anti-seizure effect. This diet changes neurotransmitter systems, including GABA, glutamate, adenosine. It changes ion channel regulation, such as calcium channels. It increases mitochondrial function and production, and that's really important. So if you do this diet for a few years, your cells will have more mitochondria, and those mitochondria will be healthier. It increases circulating polyunsaturated fatty acids, which have been found to be neuroprotective. It decreases leptin, which has an effect on hunger. It decreases inflammation, including brain inflammation. It changes the gut microbiome. There are some scientists who have published in a prestigious journal called Cell who claim that the primary effect of the ketogenic diet is its effect on the gut microbiome. It changes DNA methylation and gene expression, and then these last three, increasing autophagy, increasing levels of NAD, and activating sirtuin genes, are all thought to be an anti-aging effect. So those are some powerful effects. That's pretty impressive, right? So what is this diet being studied for? So here you go. There are published case studies or randomized controlled trials for some of these, for all of these conditions. The biggest thing I ask of you is please do not leave here and go tell people the keto diet can cure ALS and can cure Alzheimer's disease and bipolar. It can cure everything. Everybody should be on the keto diet because it will prevent all illness in the world. That is not what this slide is intended to portray. Now, I'm going to go through a few of these. If you have questions on any of these conditions and the ketogenic diet, you can feel free to ask me. I know a lot of the literature. I don't know all of the literature. So if I'm not going to cover your disease of choice, feel free to ask me in the Q&A. I'm going to go through Alzheimer's disease. So what causes Alzheimer's disease? No one knows. The current answer from the best academic society says no one knows. We know that it is associated with higher levels of plaques and tangles in the brain. Why do those form? No one knows. What are those there for? No one knows. Will getting rid of them improve clinical outcomes? The FDA just recently said, yeah, we think so, maybe. And as you may have read, a lot of prominent scientists quit their service over that decision because that is not at all founded in science. And the clinical trials of aducanumab actually showed that it did not change the clinical outcomes, even though it did reduce the plaques. But what we do know are risk factors. What are the risk factors for Alzheimer's disease? Diabetes, obesity, cardiovascular disease, or cardiovascular risk factors. You might think of those as metabolism. Lack of exercise, maybe throw that in with metabolism. Poor sleep. If you don't know that already, throw that in with metabolism. Depression. Recurrent episodes of depression earlier in life double your chances of getting Alzheimer's disease. And ApoE4 allele. What does ApoE do? ApoE is an enzyme that's related to cholesterol and fat metabolism. Mitochondrial dysfunction has been shown, and brain glucose dysregulation has been demonstrated and directly correlates with the plaques and tangles and the clinical symptoms, so that some people are calling Alzheimer's disease type 3 diabetes. Do we have any evidence that the ketogenic diet actually changes the course or improves symptoms with Alzheimer's disease? We have some small pilot trials. That's all we've got. Small pilot trials, but I'll share them with you. We have at least 3 animal models showing that the ketogenic diet can reduce biomarkers or even the plaques and tangles associated with Alzheimer's disease. We have 1 study showing that a ketone supplement, these patients didn't have to change their diet, they were just given a ketone supplement, that actually, the ketone itself seemed to improve cognition in the patients who did not have an ApoE4 allele. There was a very small study, 23 people randomized to a high-carb or low-carb diet. The low-carb diet had memory improvement, and it was the level of ketosis that was the single factor correlated with improvement. It was not correlated with calories consumed, the way they measured insulin resistance or insulin levels, or their weight. You didn't have to lose weight in order to get a clinical benefit. This next study, I want to just highlight one of the challenges in our field that we all face. This was a Johns Hopkins study, modified Atkins diet versus the National Institute of Aging diet for 6 weeks. After 2.5 years, they screened over 1,300 people. They were shooting for 60 completers. They got 27 people to even enroll in the study. And they only had 14 complete the study. You don't get a really robust statistical significance with 14 patients. Nonetheless, the patients who achieved ketosis seemed to have improved cognition. And by their metrics, it was clinically significant. But people will ignore this study because it's only 14 completers. They spent a lot of money, a lot of time on this study. They screened over 1,300 people who had Alzheimer's disease. They didn't want to do this diet. This next study is a little better because they got 90 to 95% compliance. They randomized 20 participants to both a ketogenic and an American Heart Association diet, separated by a washout period. And they found that when people were on the ketogenic diet, they had improved biomarkers of Alzheimer's disease. Biomarker is different than clinical improvement. This is probably the best study we've got. 26 participants, just came out this year. They were randomized to 12 weeks of either a ketogenic diet and a low-fat diet separated by a 10-week washout. The patients who got the ketogenic diet had clinically significant and statistically significant improvement in activities of daily living, which means these people were better able to wash themselves, eat, feed themselves, those types of things. Quality of life. And they actually had improvement in cognition, but with the 26 participants, it didn't reach statistical significance. But before you go tell little grandma in the nursing home who's been there for 10 years, who's in the end stage of Alzheimer's disease, before you go tell grandma to do a ketogenic diet, Alzheimer's disease is associated with neuronal atrophy, which means shrinking, and cell death. Once brain cells die, for the most part, there are a handful of areas in the brain that can regenerate cells, but for the most part, once neurons die, they're dead. That's why stroke patients do so poorly. You don't get it back. And the ketogenic diet doesn't resurrect dead cells. So there might be a point in Alzheimer's disease beyond which it's too late to intervene. So now we're going to talk about mental disorders. And a lot of people are like, what the hell are you talking about mental disorders and a diet for? Like, what do they have to do with each other? This is mental. So I start with the question, what causes mental illness to begin with? The predominant model is called the biopsychosocial model, which says there are biological factors, psychological factors, and social factors that all come together to result in mental illness. This applies to every mental disorder. It applies to schizophrenia. Psychological and social factors influence the development of schizophrenia. So schizophrenia, most people think of it, that's a biological illness, but psychological and social factors play a role. This applies to every mental disorder. And you see some of the factors that are listed, and I'm here to ask the question, could metabolism play a role? Because nobody ever, for the most part, talks about metabolism when they talk about the biopsychosocial factors, including the biological factors. Metabolism is a biological thing. Almost never does anybody in the mental health field say metabolism might be an important factor to consider. So I'm going to walk you through just a tiny whirlwind tour of some of the literature on the connection between what we call mental disorders and metabolic disorders. Turns out that mental disorders have a bidirectional relationship with all metabolic disorders. What do I mean by bidirectional relationship? I mean that if I look at a group of people with mental illness, they are more likely to have, in this case, obesity. If I look at a different group of people who are obese, say I go to a Weight Watchers group, they are more likely to have a mental illness. Major depression, bipolar disorder, schizophrenia are all associated with higher rates of obesity. For depression, it's not that bad. It's only a 20% increase. And you have to take that into the context of some people lose weight with depression. But when you look at patients with bipolar disorder and schizophrenia, this one study followed patients for 20 years. After the first hospitalization, 2/3 of patients with schizophrenia and over half of those with bipolar disorder became obese. And this compared at the time to rates that were like 17% in New York State. So I know the rates of obesity are skyrocketing now, so these rates may seem like, well, that's probably normal. It was not normal. It turns out that individuals with a higher BMI, so people who are obese, if you measure their brain function, they actually have abnormalities in the brain circuits and the way that they communicate with each other. And these same abnormalities are found in patients with mental disorders. Obesity actually worsens the course of bipolar disorder. So if I have a bipolar patient, one who's obese and one who's not obese, the obese patient is more likely to have manic episodes and depressive episodes much more frequently than the one who's thin. And obesity itself leads to higher rates of mental illness. This one very large series by Kessler found that they were 25% more likely to have a mood or anxiety disorder. And then this last bullet is a longitudinal study. They followed people, looked at, do you eat a lot of junk food? If you eat a lot of junk food, 10 years later, not surprisingly, you're more likely to have obesity. Guess what? 10 years later, you're also more likely to have major depression. So mental illness and diabetes, again, a bidirectional relationship. People diagnosed with schizophrenia are 3 times, that's 300% more likely to develop diabetes as people in the general population. People diagnosed with depression are only 60% more likely to develop diabetes. When people present with new onset schizophrenia or bipolar disorder, they often show signs of glucose dysregulation, even though they don't yet meet criteria for diabetes. And this one study followed mentally ill patients longitudinally. They come into the emergency room for their first psychotic episode. They're normal weight and non-diabetic. Most people think of diabetes as a disease of overeating. So you overeat, you get fat, and then you get diabetic. In the mentally ill, at least in this series, it worked a little bit differently. You get psychotic first, then your diabetes comes, and then you get fat. What if we look at it the other way around? Diabetes. If I go to a diabetic clinic, people with diabetes, we have the best evidence for this with depression, because depression is one of the most common mental disorders. It's not the most common, but it's one of the more common mental disorders, so it's easier to kind of see and get a signal. So people with diabetes are twice as likely to have clinical depression, but when they get it, it lasts 4 times longer than it does in people who are non-diabetic. So that at any given time, about 25% of diabetic patients in a clinic will have depression. But depression actually worsens the course of diabetes, and this is regardless of the treatment. So if you have a patient with diabetes who's stable, whatever stable is for them, on whatever treatment you want, insulin, medication, or even the ketogenic diet, if they get clinically depressed, spouse dies, they get clinically depressed, their blood sugars are going to go up, their levels of insulin are going to go up, and those people are more likely to have higher rates of vascular complications. Mental symptoms affect metabolism. What about cardiovascular disease? Same deal, bidirectional relationships again. People with schizophrenia and bipolar disorder are much more likely to have cardiovascular disease. Depression itself is a major risk factor. In people who've never had a coronary event, they are 50 to 100% more likely to have a heart attack. In those who've already had a heart attack, depression about doubles your risk of having another heart attack, if all other risk factors are equal. What if I look at it the other way around? If I go to a cardiac floor and look at people who are suffering and in the hospital with a cardiac event, 20% of people who have coronary artery disease have clinical depression, and 33% of those with congestive heart failure have clinical depression. This is 3 to 5 times the rate in the general population. Now, most people think they understand this. It sucks to have a heart attack, and it really sucks to have congestive heart failure. Wouldn't you be depressed? The problem is that the depression often came before they had these events. And maybe if we had taken that as a signal and intervened, we might have prevented these catastrophic events. And the reality is that people with mental disorders die early deaths. Mental illness is a sometimes deadly disorder. Life expectancy is significantly reduced. We've known this for decades with serious mental disorders, schizophrenia, bipolar disorder, major depression, depending on what series and study you look at, anywhere from 7 to 30 years of life reduction. But it turns out that a recent study in Lancet in 2019, looking at over 7 million people, found that all mental disorders reduce lifespan. ADHD, anxiety, depression, personality disorders, substance use disorders, every single mental disorder puts you at risk for reduced lifespan. Mortality, everybody thinks suicide, it's suicide. They're all killing themselves. They're killing themselves at young ages, and that skews the statistics. Everything I said is true. They do kill themselves more frequently than people who don't have mental disorders. That's true. But that's not what they're dying of. Most of the people are dying of cardiac disease, diabetes, cancer, Alzheimer's disease. So why consider a metabolic intervention for mental disorders? In many ways, this is nothing new. This research has been around since the 1960s. Metabolic disturbances in the brains of people with mental disorders is well known. This is science fact, if you believe in scientific evidence. The diagnoses include things like schizophrenia, bipolar disorder, anxiety disorders, PTSD, and depression. Those are the common ones that we have the most robust evidence for. What do I mean when I say changes in metabolism? Different levels of lactate, the ATP to ADP ratio, reactive oxygen species, redox markers, NAD to NADH, inflammation. These are all related to metabolism, and it is well documented that people with mental disorders have these metabolic disturbances in their brains. Abnormalities of glucose metabolism are seen in not just non-treated bipolar disorder and schizophrenia, but actually quite a few mental disorders, and I'll describe another one soon. Cortisol is known to adversely affect metabolism, and people familiar with mental health field know cortisol plays a huge role in a lot of mental disorders, and mitochondrial dysfunction has been found in many disorders. So why consider the ketogenic diet? Here is the way I think about it today in 2021, standing before you. The ketogenic diet is an evidence-based proven treatment for epilepsy. I hope you believe in Cochrane reviews. Most treatments for epilepsy are routinely used to treat psychiatric disorders. This includes medications like Depakote, Tegretol, Lamictal, Topamax, Neurontin or gabapentin, and all the benzodiazepines, Valium, Klonopin, Xanax, Ativan. Every medication I just listed, even though most of you probably know them in the use of psychiatric disorders, every medication I just listed are anticonvulsant medications. Turns out that psychiatric treatments don't work all that great for most people. So clinicians often end up using off-label treatments. The ketogenic diet has been found to reverse many of the metabolic and brain abnormalities found in people with mental disorders. Therefore, it is not unreasonable. Given that we're already using off-label treatments all the time, it is not unreasonable to consider using an off-label therapeutic dietary intervention in treatment-resistant mental illness. This can't be a first-line treatment yet. Treatment-resistant mental illness. So do we have any evidence that it actually does anything for real people with mental disorders? We've got some, and I'll go through that. So depression. Unfortunately, we don't have any randomized controlled trials. We don't even have any good clinical case studies of the ketogenic diet being used for somebody with primary major depression. Nothing in the medical literature yet. What we do have are studies where they use the ketogenic diet to treat another medical condition, such as diabetes, weight loss, epilepsy. And the researchers measured levels of depression and noticed that the patients got a lot better. Their depressive symptoms got better. The confound in that is that maybe they felt better because they were losing weight. Who wouldn't feel better if they're losing weight? Maybe they felt better because their seizures stopped. Who wouldn't feel better if their seizures stopped? Maybe they felt better because their diabetes was in remission. That's a pretty good thing to feel good about too. So we've got these clinical trials. The good news is that there are just a tiny number of clinical trials underway for major depression now. Alcohol use disorder. This is late-breaking news just this year. And this comes from the National Institutes of Health. And the lead author was, or the senior author, I should say, was a woman named Nora Volkow, who is the director of our National Institute of Drug Abuse. Turns out that alcoholism has been associated strongly with brain glucose hypometabolism. The brain cells of alcoholics tend not to metabolize glucose very effectively. And there's a lot of reason, based on a lot of neuroscience literature, to believe that this might be related to the reason it's so hard for alcoholics to stop drinking alcohol and why they get such a potent, powerful reward when they do drink alcohol again. And that makes it very difficult for them to stop. Animal models have directly demonstrated reduced alcohol intake in rats on ketogenic diets. But this study recruited about 40 patients with alcoholism. They brought them on an inpatient unit for a detox. They randomized half of them to a ketogenic diet and half of them to the standard American diet. Everything else was the same. The patients on the ketogenic diet required less benzodiazepines as part of their detox. Even though they got less medication, they had fewer withdrawal symptoms. And they reported lower cravings for alcohol. And in fact, these researchers did brain metabolism studies before and after. So scans of their brain metabolism before and after. And in fact, the patients who got the ketogenic diet had improved brain metabolism in the areas that these researchers were most interested in, that they thought might be playing a powerful role in this addiction cycle. Schizophrenia and bipolar disorder. For those of you who don't know, schizophrenia affects about 1% of the population, bipolar 2 to 5%. Rates are going up, so these are probably dated statistics, unfortunately. There's a lot of overlap in symptoms and diagnoses, and in fact, these diagnoses are really considered a spectrum disorder now. They're really not distinct illnesses, and that's why I put them together. For those of you who don't know though, in a 3-year observational study over 6,000 patients with schizophrenia, our current treatments are abysmal in terms of helping restore these patients' lives. 6,000 patients, how many of them got long-lasting symptomatic remission? 33%, that just means your hallucinations or delusions go away. How many of them had an adequate quality of life? We're not even shooting for good quality of life. We're shooting for adequate quality of life. The only other option is poor quality of life. Only a quarter had an adequate quality of life. How many of them are able to work or go to school? Only 13%. And if you put those all together, you have to have all of those to call it a really effective treatment, 4%. So we need better treatments for these disorders. So does the ketogenic diet work? Do we have any evidence that it works? We've actually got 5 animal models published in reputable neuroscience and psychiatric journals now showing that the ketogenic diet can have an antipsychotic effect in animals. The human data goes all the way back to 1965, a pilot study of 10 patients with schizophrenia. Patients were placed on a ketogenic diet for 1 month on an inpatient setting. The researchers reported that the patients who got the ketogenic diet were significantly improved. When they stopped the diet, symptoms got worse. I'll fully acknowledge this was a very poorly done study because studies back in the 1960s weren't all that rigorous. So we do have more evidence. The 2009 study is from Dr. Eric Westman, but I'm going to skim through these. I have published 3 different case series or a small pilot study. And instead of going through statistics and data, I'm going to tell you a story about one of these patients. And some of you who've heard this presentation before have heard the story of Doris, who is now in her 80s. And she is really a testament to it's never too late to intervene, but I'm not going to tell her story this time. I'm going to tell a more complicated story, for better or worse. I'm going to mix things up. I'm going to call this woman Jane. That is not her real name, but this is her real story. So Jane grew up in the Midwest to a middle-class family. She had no trauma or abuse. She had a good life, but she was anxious as a kid, always anxious. Never clear why. Parents didn't really know what to do. They did their best. Teachers did their best to support her. Over time, she got diagnosed with an anxiety disorder, then depression on top of that. She started treatment, medication, psychotherapy. Wasn't really working. By the time she was 14 years old, she began having hallucinations and delusions. She started getting paranoid. People were following her. People were trying to harm her. She didn't tell anybody, though, because she knew that they would think she was crazy. So she kept that to herself. Her depression started getting worse. She started attempting suicide, was hospitalized for those suicide attempts. More pills, more therapy, more hospitals. Nothing's working. She develops anorexia nervosa. She starts starving herself. She becomes completely emaciated, super thin. She doesn't have obesity. She's the opposite end of the spectrum, super thin. Hospitalized a couple of times for her anorexia nervosa, which is a life-threatening disorder. For those of you who don't know, it's actually the most deadly psychiatric disorder to be diagnosed with. Nothing's working. By the time she's 23, she gets the official label of schizophrenia because she can't conceal her hallucinations and delusions anymore. Pills, pills, and more pills, lots of therapy, some hospitalizations. Nothing's working. By the time she's 33 years old, she develops a lot of gastrointestinal complaints. Pain, cramping, trouble with certain foods. They do a medical workup, can't find anything wrong. It's in her head, clearly it's in her head. They try different standard treatments. Those standard treatments don't work. So she goes to a functional medicine practitioner who says, let's put you on a ketogenic diet for these GI problems. She starts the ketogenic diet. Within a couple weeks, she starts feeling a little bit better. At this point in her life, she's on 14 different medications. She's sick of medications. She makes a strategic decision. I'm going to stop all my meds. She stops all her meds. Now, I want to point out, this woman is in ketosis. That should save her, right? In ketosis. She stops all 14 meds. All hell breaks loose. She becomes floridly psychotic, severely depressed, suicidal. She's hospitalized. Hospitalized for 2 full months. For those of you not familiar with psychiatry, that's a long time to be in the hospital. They allow her to remain on the ketogenic diet because she's got a GI problem. They put her on an injectable antipsychotic medication called Haldol. She has tried this before and it never worked, but they're going to try it again. At least it's injectable, she can't stop it. And within 1 month, her hallucinations and delusions stop for the first time since she was 14 years old. Over the next year, she works with her psychiatrist to wean off of the Haldol injections. The hallucinations and delusions never come back. So now she's off all antipsychotic medications and her hallucinations and delusions are gone. I want to point out, she loses 70 pounds from the ketogenic diet. She only needed to lose 40. She is now 30 pounds underweight. And she readily acknowledges, I was getting a high. The power, the control that I finally got again. I loved it. I loved losing weight. She worked with a therapist to regain that 30 pounds. She has been able to maintain a normal, healthy weight for the most part since then. It is now 8 years later. She has remained out of psychiatric hospitals. She has remained off antipsychotic and mood-stabilizing medications. She no longer has, the psychotic symptoms. She's still tempted. When she gets really stressed, she says, I'll start restricting. I start cutting back on my carbs, maybe the calories. I want that high. I want the control. I want to be able to control something when I feel like my life is getting out of control. And she works with her therapist to recognize that dangerous pattern. And she has been able to control her anorexic symptoms since then, while doing a ketogenic diet. She's also gotten married. She finished a master's degree in social work. She now works full-time as a social worker in a mental health clinic. The people in the mental health clinic do not know anything about this history. They think she's just a normal woman who's a social worker. They have no idea that she has this history. And so she's not a public figure. She's not willing to come out about this because she has a life that she wants to protect. So how would you implement the ketogenic diet for mental illness if you want to do it? Patients, please do not try this on your own. I cannot stress this enough. There are serious risks, especially during keto adaptation when this diet is initiated. So in my clinical practice, I can theorize why this is happening, but I'm just reporting the facts. The facts are a lot of people will get insomnia. They can actually have increased depression before their depression alleviates. They can have increased suicidality. Some patients get manic. Some patients can have increased psychosis. In other words, it can get worse before it gets better. This is usually in the first month, usually in the first 2 weeks for most patients. But the first month is particularly dangerous as they are adapting to the ketogenic diet. Hypomania and mania are common, but usually unrecognized. Psychiatric medications can interfere with the diet's effects and might prevent a recovery. Antipsychotics increase insulin levels and increase glucose levels. They need to be safely managed. We just heard a story I shared with you about a disaster. So please don't do that. And the reality is this is not a magic bullet for most patients. It's not. It is one part of a comprehensive treatment. Patients need medication monitoring, medication reduction, maybe even medications. They need to sleep. They need a daily routine. They need exercise. They might need therapy or stress management. If they're using drugs and alcohol, guess what? That can play a role in their illness and their metabolism. So what do you need? You need a competent mental health professional, and you need a competent ketogenic diet clinician to deliver this treatment. It could be one and the same, but I really feel strongly you need both of these. You need medical record documentation, and then the options are you might employ a keto coach or a keto food service. Here are some points to consider when thinking about medical record documentation. I'm not going to read through them, but you have the slide available. So if you're a clinician and you're thinking about doing this, I don't want you to lose your license. So please document why you are using this and why it is a reasonable, justified decision. The patient has to be informed of their treatment options and that this is an off-label treatment. The future of this field is bright. There are psychiatrists and neuroscientists around the world, some of the top in our field, who are beyond excited about this. I shared with you Nora Volkow. She's a director of NIDA. That's important and impressive. But one group of researchers actually stole this idea. They talked to me a year beforehand. They published in a journal. The ketogenic diet might be an effective treatment for schizophrenia, bipolar disorder, and chronic depression. And here are all of the reasons why it might be. They didn't mention my research at all. They didn't mention my collaborator's research, who's done a lot of the animal studies of this. So we got another publication by submitting a response to there. But the fact that a really prominent neuroscience researcher thinks this is worthy of stealing, in my mind, yay, this is great, great news. People in my field are taking this seriously. They know that we have more than enough of an evidence base to take this seriously because we have so much literature in the neurology field that we routinely call on to treat psychiatric patients. So with that, I will stop, and I am happy to take questions. And I just want to say, I'm a mental health professional. I'm happy to take questions on anything I discussed, keto diet, but if you have questions about mental health in general, I'm also happy to take those.
I will be the first one to say I will buy that, so thank you so much. And thank you for such an inspiring and hopeful presentation. I lost a brother to schizophrenia and a sister-in-law to bipolar, so the fact that there could have been some additional interventions is hard to take, but again, it's very hopeful. My question to you is, when you were going over the various mental disorders that could possibly benefit from a ketogenic diet, and you were citing the studies, were they all using a traditional ketogenic diet, or was there variations in the type of diet that they were using?
It's a great question. So all of the animal model studies that have ever been done employ the traditional 4-to-1 ratio ketogenic diet, and that's really important to take into account when interpreting this literature. And that includes all of the neuroscience. So all of the neuroscience that we have about the ketogenic diet is based on 4-to-1 ratio diets. The clinical trials and or the clinical case vignettes are variable. Some of them use Dr. Westman's version of the ketogenic diet for weight loss and diabetes control, fairly kind of, you don't have to weigh and measure, you can just guesstimate, a handful of this, 2 handfuls of that, and you're good. Others, I've had many patients who have needed a 3-to-1 or even a 4-to-1 ratio diet in order to achieve a therapeutic effect. So the way that I look at the ketogenic diet is I look at it as just like any other medical intervention. If you're going to give a pill to a patient for a condition, what dose do you use for everyone? Well, we don't use the same dose for everyone on any medical intervention. You have a starting dose. My starting dose of the ketogenic diet is the modified Atkins diet, which is a 2-to-1 ratio diet, guesstimate. Don't have to weigh and measure, but let's shoot for a 2-to-1 ratio diet. I will have them track sometimes if we're not getting ketosis or if we're not getting high enough levels of ketones. I am shooting for a range of ketones, almost always greater than 1.5. For psychotic disorders, I'm usually looking for greater than 2 or 2.5, ideally above 3. But I've seen some people benefit from just getting over 2. Below 2, I haven't seen much of a benefit for psychotic disorders. So that means you're really doing a therapeutic ketogenic diet, and it's important to do blood monitoring. But I start with 2-to-1 ratio, modified Atkins, and if we're not getting an effect, if we're not getting ketosis, then we start getting more rigorous. Maybe let's try a 3-to-1 ratio diet. Maybe let's monitor and make sure you're actually doing 2-to-1 ratio. Let's up the ante, and we up the ante and see what we get.
Thank you. Thank you. Can you please talk about your experience with autonomic dysfunction in your patients and what methods have been the most effective? I'm particularly interested in the limbic system retraining I've been reading about.
So I would defer to our prior speaker on that one. That's not an area of expertise of mine.
Okay.
So I'm not treating a high. I have 2 patients who've had autonomic dysfunction, and I've used this intervention. They also had very serious psychiatric diagnoses on top of their autonomic dysfunction. But I'm not really qualified to answer that question.
Okay. I would think they would go hand in hand.
I think they do go hand in hand. My clinical sample isn't that population.
Thanks for your talk. I do family medicine, so I've noticed, I appreciated the section that you had talked about, the use of the off-label epilepsy drugs and how they can be used in bipolar and kind of how that might correlate to doing a ketogenic diet. So my question is, when you notice very, very strict protocols in inpatient hospitals for, let's say, childhood epilepsy, it's well accepted the ketogenic diet is used. There's no question, there's no, argument against it. Does that give you hope, or have you even seen inpatient centers, recovery centers, detox centers, inpatient, starting to implement those dietary changes? Because, do you see hope in that? Because I could see that potentially reducing inpatient stays in a mental health facility, things like that. So I was just seeing maybe if you could comment on that.
Yeah, I see a tremendous amount of hope. And I'm actually ramping up to start more of an advocacy campaign, but also a research campaign. So we've got 3 funded clinical trials of the ketogenic diet for bipolar disorder, schizophrenia, and schizoaffective disorder. Yeah, thank you. That was a long time coming, and there is a very wealthy philanthropic family that has set up a foundation for exactly this purpose. They are very passionate about seeing this move forward. So, but change is hard, as we all know, and as many people have talked about. So we do need research. Science and facts are part of the equation to change. But they're not the only one. We need advocacy, we need lobbying, we need all sorts of things. And the reality is we're up against very powerful forces that have reasons to resist change.
What do you think separates that epilepsy treatment in children with ketogenic diet with providers catching on to mental health disorder treatment?
So right now it's an education and advocacy campaign. I will tell you that when I speak with mental health clinicians, at least when I do, in my experience, so I give talks at Harvard Medical School psychiatry conferences, traditional, hardcore evidence-based psychiatrists come to those conferences. That's what they're scrutinizing. And I just gave a talk 2 months ago, and in fact, it was the highest rated talk of the entire conference. Multiple people said, this is really serious. 2 researchers said, we're going to pursue research on this. And many clinicians said, I'm really going to consider the ketogenic diet with some of my patients. Here's the big challenge and conundrum. I cited the Johns Hopkins study, how difficult it was for them to get old people to do the diet, to potentially prevent or reverse or slow down Alzheimer's disease. 1,300 people, 14 completers, that's it. Those people knew what they were doing. Those researchers knew the ketogenic diet like the back of their hand. They were trained. When I give a talk to general mental health practitioners, they don't know nothing about the ketogenic diet. They don't know what all is involved. They don't know the art and the science. How do you get people to do this? How do you make it palatable? How do you make it doable? But we have to combine art and science. We really do. There's an art to this, and many of you in this room are professional in that. You know good recipes. You know good tips and tricks for when you're eating out with friends and family who are shoving bread in your face. That's the art of implementing this treatment, but there's a science of implementing this treatment. Do we start with a 2-to-1 ratio diet? Do I go up in the diet? Do I add MCT oil? What happens if LDL goes up? How am I going to respond as a medical provider? That's the science. So it's got to be a team effort to really move this forward. But I am full of hope, and the thing that gives me the most hope is that people with mental disorders are pissed off. They are frustrated, they are hopeless. And I've got billionaire families saying, we will throw money at this if you have an effective strategy to change. Just move the needle, for God's sakes. Just move it for even 10% of the patients. Like, we are so sick of this hopeless message that no one knows what causes schizophrenia. No one knows what causes bipolar disorder. Yeah, our current treatment sucks, and so you just have to accept that your life is ruined. Sure. That's not something really to clap for, but well, I get it.
Yeah, that was like the $1 million question, you know, of pretty much everything you said and everything that we all work for is to try to figure out how to get the word out and let everybody know that it's not just psychiatric, it's like 1 million disorders that could be fixed by not having the SAD diet. So that being said, you mentioned something about APO4 alleles, and I'm wondering if you have any research literature, anything that could help understand whether or not being on a ketogenic diet will increase your risk of Alzheimer's, dementia, with either 1 or 2 alleles of the APO4 gene.
So I'm going to encourage you, if you don't know him, you can just follow him on social media. His name is Nick Norwitz.
Dave just told me about him.
He's a friend of mine who is now in his first year at Harvard Medical School. So he's going to get busy really soon and really fast. And he has self-disclosed, so I'm not disclosing anything confidential. He is double ApoE4 on a ketogenic diet for his own health conditions. And he's particularly concerned. Oh my God. I don't want Alzheimer's disease when I'm 60 years old. And am I hurting, helping? So right now we don't have a definitive answer. We really don't. But he, probably more than anyone, is passionate about looking at the hardcore science literature, trying to connect some dots and try to make sense of what am I doing to my body, and is this really in my best interest?
So just to follow up a little bit on that, in terms of research and studies, do you have anything like that you're giving us in your slides that has stated research so that we can look at that and use it?
So the best place is to go to my website.
Okay.
So my website, I have my own publications. And I've got a lot of lay articles that I've written for like Psychology Today and other things on all of these topics. If you read any of my own publications, you'll see a lot of citations of the major kind of, articles in the field, all kind of linking it. I will just share with you, I've got a book coming out a year from now, so stay tuned for that. And that will actually provide a lot more of the science and will connect even more dots than I've connected for you today.
Thank you so much.
Eric Westman, Durham, North Carolina.
Dr. Westman,
It's for
I've
the
heard of
Zoom
you.
people. Thank you so much. Great talk, as usual, and also thank you for pursuing the with academic rigor, this area, this topic. Now, in my office, I have a list of foods that you can have. The keto foods, low carb, high fat, LCHF, whatever you want to call it, very low in sugar. Then I have this box at the bottom. It has a red, surrounded with a red line with an arrow through it, the no-no list, as it were. These are the foods that are eliminated on a keto diet, well-formulated keto diet. And so I'm sitting here looking at this and thinking, is what I do effective because of the food I give or the food that's removed? And so I remember, we're treating things get better and all. Can things be prevented? Now, I'm convinced that I can prevent diabetes, though I don't have a clinical trial on it. It's a harder study to do. But I'm convinced that if you don't eat much sugar and starch, you're never going to get diabetes. And I would like someone to show me an exception to that rule. Now, I wonder, can you prevent schizophrenia? And I seem to recall there was a kind of observation that when famine or war came through, there was rationing of bread, and there was a suspicion that bread might actually be causative. So is the effect of what we see the effect of the food you're giving in the keto levels, or is it because they're not having something that causes the brain abnormality?
It's a really great question, one that I've thought a lot about, and one that I think about and explore pretty rigorously in the book that I've written. And the real answer is, can we prevent all mental disorders? So can I eliminate schizophrenia in the population? My unequivocal answer to that is no way. And the reason that I say that is that even if I get everybody, which I would not advocate for, but even if I get everybody according to that hypothesis, no more sugar, no more carbohydrates, everybody eat meat and drink water, nothing more. Will that alone prevent schizophrenia in all of those people? I would argue no, it won't. It will dramatically reduce schizophrenia, in my opinion, based on a lot of science, connecting a lot of dots. But there's a lot more. So my shtick is that metabolism affects brain health. But in order to really unpack that, you have to understand, well, what is metabolism? Metabolism is a lot more than just diet. Metabolism is life. Metabolism is how do living organisms live and reproduce. That is metabolism. Everything that goes into how do living organisms live and reproduce and adapt, everything related to those concepts is related to metabolism. And that means, for instance, if you're a mother and you get a viral infection during pregnancy, especially in the second trimester of pregnancy, your child is more likely to have schizophrenia, regardless of what you're eating, regardless of anything else. There have been pandemics, other pandemics, that resulted in skyrocketing rates of autism, because we know that infection results in inflammation, which affects metabolism, but it affects neurodevelopment. It affects all sorts of things. But again, let me make this relevant for everyone in this room. You're on a therapeutic ketogenic diet. You're doing great. You're doing so well. Everything's good. Your blood sugars are good. Your cholesterol's good. Everything's great. You've reversed your diabetes through Virta Health. You get an infection. What happens to your blood sugars? Because you got an infection, what happens? This is not theoretical. The overwhelming majority of people who get an infection will see their blood sugars go up. Their levels of insulin resistance will go up, regardless of what they do with their diet at that point. They can starve themselves, they can fast, they can do whatever they want. They can increase their fat ratio. It's not going to make the glucose go down necessarily, because an infection is a stress response. Your body is responding in a metabolic way. Your body is devoting resources to fighting off something that may kill you. And when it is devoting resources to something else, it means that it has fewer resources for maintenance and just general life happiness and everything else. And then if you are vulnerable, so not everybody has an increase in glucose because some people are really resilient and healthy. But I'm talking about people who've had diabetes, even if they've reversed it. They are a vulnerable population. Why? Because they had diabetes. Whatever happened to make them get diabetes put them at risk. And so now they're a vulnerable population, and when you threaten that vulnerable population with an infection, but also with abuse, with stress, with sleep deprivation, maybe changes in the gut microbiome, maybe lots of other things. But when you threaten that organism, that human being, and they have to mount resources to defend themselves, it takes a metabolic toll. And I don't consider that illness. I consider that an adaptation. That is normal. That is healthy. We have to do that. We have to defend ourselves. And there's always a price to pay to defend ourselves. So we know that stress itself, bullying and teasing a child relentlessly, making sure they don't have any friends, they're also getting abused at home by parents. Later, when they become an adolescent, they get sexually molested. Those children are at higher risk for all mental disorders, all of them. Not just depression, not just anxiety, not just PTSD. They're at higher risk for having hallucinations, which get diagnosed as schizophrenia or bipolar disorder. They're at higher risk for alcoholism. They're at higher risk for every mental disorder. And if they were on a low-carb diet through all of that, is that a powerful enough intervention to negate all of that? Sexual abuse, physical abuse, bullying and teasing, no friends. I would argue no. We don't have clinical trials to test it, but I would argue in my common sense way, no, I don't think that's a powerful enough intervention.
So what you're saying is not just the bread.
It's not just the bread. It's not just the bread, and it's not just the sugar, although bread and sugar are important, powerful tools that we can use to improve metabolism. So I don't want you to take that away from, take away from that. Like Chris Palmer's not saying diet doesn't matter. Diet absolutely matters, but diet's not the only thing that matters.
Chris, what I can say after your presentation is amen. As you know, I'm not a practitioner. I am a long practicing patient. So I have 4 or 5 1- or 2-word answers, okay? Number 1, does my psychiatrist work for me, or do I work for my psychiatrist?
That's a question to me?
Yes, it is.
Your psychiatrist ideally should be working for you.
Okay. Number 2.
Hi, Dr. Palmer. Thank you very much. I just wanted to ask you, in my obstetric practice, I have a fair amount of patients with psychogenic non-epileptic seizure disorder, and they usually roll in like a full-on seizure type activity into my unit in labor and delivery transferred from an outside center. And I'm just wondering, do you have any experience with those types of patients who have PNES? And then if you've ever considered this kind of treatment, or what is your approach? Because I feel like when we get neurology involved, they end up sending them with Lamictal or something, and or Keppra, and then I just feel like it's the wrong approach, and I feel like a lot of these folks have PTSD and things like that. And so can you just give me your approach and how it fits in terms of ketogenic diet? Thank you.
It's a great question with not an evidence-based answer. So the reality is, you're describing a patient population that everybody in the medical field considers difficult. These are the difficult patients because we don't have tests to really say what's wrong with them, and when we can't get a positive test that tells us, oh, here's pathology, then we think it's in their head, they're faking it, they're doing this on purpose to get attention. There's no doubt there are probably some patients who are, in fact, doing it to get attention. Maybe they've been abused, maybe they're neglected, maybe they just got in a fight with their boyfriend and they want to get attention, and so they fake a seizure. But with a lot of them, I mean, basically what you're describing is a very old-fashioned concept called conversion disorder, or some people might call it somatization disorder, or somatoform disorders. Lots of labels that we apply to it. But people with mental conditions are more likely to have physical complaints. And what causes those physical complaints? The predominant model right now is that it's just in their head. I don't believe it's just in their head. With pseudo-seizures, it's more difficult to assess because I really do think there are some circumstances where people are doing it for some kind of a reward. And that might be, I want attention. Somebody's neglecting me and they're forgetting that I'm sick. And they won't believe that I'm mentally sick. They don't like my PTSD symptoms. They get annoyed at me for those. So if I fake a seizure, they'll pay attention to me. They'll be more concerned. They'll be more loving. They'll care give more. There's no question in my mind that that is true for some patients. And then the solution for that patient is to address that issue. To address, you know what, yeah, I get that it gets you some short-term caregiving, but you're burning out your boyfriend. You think he's going to be with you 5 years from now? You think he's going to be with you 20 years from now if you keep this up? You're going to have to find a better way to get attention. You're going to have to, and you need to give a little and get a little, and you need to be able to communicate with him and talk with him about your needs and how you're going to get them. And maybe your boyfriend's not capable of giving you everything you need, so then you turn to family and friends and other people. So for that patient, those are the kinds of strategies I would use. For another patient who says, I really wasn't faking it, and I genuinely believe that she wasn't, that she was really having some experience that resulted in her being distressed and almost passing out, I actually think metabolism may, in fact, be playing a role. That, with autonomic instability, with muscle, effects and other things, that when metabolism is disrupted, when diabetics report feeling fatigued all day and that they can't exercise because they're fatigued, most people in our society just think that's laziness. I actually think it's a metabolic problem affecting their brain function, but also affecting their muscles. They really can't exercise. Or if they can, it is really painful for them. It is genuinely painful for them. And it's taking a gargantuan amount of effort for them to do it. And it doesn't mean that I don't ask my diabetic patients to exercise, because I do. But I do it with that kind of a compassionate understanding. This is going to be huge for you, and I'm asking a lot of you. But I think, again, short-term detriment, this is going to really hurt. You might have more pain. You might even have more fatigue in the short run. I'm not going to be deterred. You might, but I'm not going to be deterred because I'm expecting that. I want you to expect that, because that's the path to recovery. And so I might use that kind of an approach with someone else, but I could go on, but I'll take another question, sorry.
Thank you. What are your thoughts about the use of exogenous ketones and MCT oil in those dementia and behavioral health patients? I'm wondering if it would attenuate risk in that induction phase. Any thoughts on that?
So it's a really important question. Dom D'Agostino is doing research on this. Mary Newport is championing that effort. She treated her husband with ketone supplements and MCT oil and other ketogenic agents and found that it was beneficial and helpful for him. He is dead. He passed away he fell, started having seizures and died. So again, we're not talking cure, but she reported significant improvement in his symptoms over a period of time. She's written a book on this. But we don't have rigorous studies. We just don't. The reality, again, the best research that we have, I showed you, and they're tiny, tiny studies in the grand scheme of the medical industry. A study with 26 patients is a pilot study at best. So we need to champion this. And I'm a big fan of, we need to champion this based on neuroscience. We need to champion this based on evidence, not on, I did keto and it worked for me, so let's do it. Everybody should do it. Because then you sound like a snake oil salesman. You really do. I did keto, it worked for me, everybody should do it. That's nothing more than a snake oil salesman. We have so much evidence to call on. We have such a tremendous gift and opportunity by all of these neuroscientists and others who've done the research. We need to use it in a strategic way to really make change.
Oh my gosh. So, all of us are clearly looking for evidence and studies to share. And I am very interested right now in glioblastomas for a very personal reason, not my own, but and I'm wondering, is there any good study evidence about ketogenic diets for glioblastomas, or for once you've gone through the surgery and then you're going to be doing radiation and chemo, of being on the ketogenic diet, and where can I find that?
So Thomas Seyfried wrote the one case report that I described just briefly when I was describing different versions. So he had success in reducing the size of a glioblastoma in a patient over a few months. It reduced in size enough so that it was undetectable on brain scans. She had to do a 4-to-1 ratio diet, 600 calorie restriction in order to achieve that result. She went off the diet, the tumor came back quickly, and she died. So those are the facts. The researchers involved and the oncologists involved thought that it was highly unusual that her tumor should regress in that way, and so the journal published it because they think this is an unusual finding. These tumors usually don't regress like this. That was an extraordinarily restrictive diet that she clearly couldn't sustain. She did it for, I think, 9 months or something like that. Don't quote me on that, but she did it for a period of time. There are plenty of studies. You might want to work with Miriam Kalamian. That's what she does. So I would refer you to her because she probably knows. She definitely knows better the literature than I do on that. So I would ask her that.
I got her card.
Great.
Hi, Dr. Palmer.
Hey.
First of all, thanks a lot for the landmark work that you're doing for the psychiatry field. And as a psychiatrist, I wanted to express my deep admiration and I wanted to publicly thank you for the work you're doing and facilitating the work for the rest of us, at least showing the way. My question has to do in regards to what I call social keto adaptation. And what I've seen among my patients is that one of the toughest things, even in mild or not very restrictive low carbohydrate diets, it is hard for them to go back to their houses and formulate it in an appropriate way, even when they have clear boundaries to do it. Do you have any, can you talk a little bit more about how you work with their families, or how important is the support that they might get from their families or environments?
It's a great question and a really important one. One of the cases that I ended up reporting on of a woman with schizophrenia who did it, her boyfriend had to lock the refrigerator, put a lock around the refrigerator, and he kept the key in a safe place at night because she was on medications, antipsychotic medications, that had for a long time caused her to wake up in the middle of the night, sometimes not even aware she was awake, and start eating. And she couldn't be held accountable for sticking to a diet in that state. She was impaired. She was sometimes half asleep or maybe even sleepwalking. And so that's an example of the extreme support some patients need. There's no question. Basically, the literature and the tools and the resources that I call upon when I think about this are the same ones of if I'm working with an alcoholic patient and I'm trying to get them to stop using alcohol, every tool that I think about and consider with those patients, I think about and consider when implementing a ketogenic diet with a psychiatric patient. And so there's not a thumbnail answer to that. It's stop drinking alcohol, stop eating carbs. That's easy to say. It's really hard for the majority of people to do. And so it depends on the person, and it depends on what are the biggest obstacles and what are the biggest challenges. And so the first thing I do is I talk to them, just in a pragmatic way. What happened? You're not in ketosis. Can you help me understand why not? Are you still on board with this treatment plan? Are you giving up on the treatment plan? Where are we at? Because you're not in ketosis. I see that. No arguing, no shame, no blame. You're not in ketosis. Should I be adding more antipsychotics? Well, what do you want? What do you want? Do you want traditional treatment? Because you know how that's worked out for you, but I can keep doing that if that's what you really want. Or do you want this potentially life-changing treatment? So that's all motivational interviewing. Everything I just said is motivational interviewing. But I'm always giving them a choice. Always giving them a choice. I'm never saying, you better stop doing, you've got to do this. We're done. I'm never doing that. I'm telling them these are your options. I'm going to take my opportunity to point out I think that's a really sucky option, but if that's what you want, I'm happy to go along with it. And then it's really doing a deep dive with the patient. Who are your triggers? Is there a specific family member, boyfriend, someone else, friend who's really pushing you? Is it the holidays that throw you off? Is it a particular night that throws you off? Is it the use of alcohol that throws you off? Well, I'm supposed to be able to drink wine on keto. But every time I drink wine, that's when I end up, oh gosh, those chips look so good, and I start eating the chips, and that's when I'm off. Why are they off? Well, alcohol can stimulate cravings for carbohydrates in some people. Alcohol also reduces your cognitive function, and it releases your inhibitions. And so those might be periods where a person's more vulnerable to not stay with the plan. And then I'm going to have to come up with a solution with that patient. How important is this treatment to you? Are you willing to give up alcohol? Or can we somehow find a way for you to safely use alcohol and lock the refrigerator if we need to? I didn't recommend that. The patient and her boyfriend came up with that treatment plan, but you have to come up with ideas and skills. But it's a never-ending issue. Once patients get about 6 months under their belt, they're off to the races. And I'm usually not having many of these conversations at all with them at that point. But the first 6 months can be really, really challenging.
Thank you, and count on me on the translation to Spanish of your book.
Awesome, thank you.
Okay, so we've got 2 minutes. If we can make it really quick.
Yes.
I don't think we're going to get to you, sorry.
So when you were presenting the data and the literature that's available, you presented a case series of 2 people with schizoaffective disorder that you've written up, and I believe 2 people with schizophrenia that you've written up. The impression that we're left with is that you have more than 2 patients with schizophrenia and 2 patients with schizoaffective disorder who have been successful with this approach. Is that part of the book that's coming out, or when can we expect that in the peer-reviewed literature, or can you speak to that?
So I'm happy to speak to that. So I've published 3 studies so far, 6 patients total. They're all unique patients. The reality is case reports and case series only go so far in persuading clinicians and the medical establishment. And I feel like we're done. I personally, I'm done with that. There's more than enough. We've got good, robust animal models in the literature, and I have very distinguished, high-powered neuroscience and psychiatry leaders talking about, oh my gosh, this makes sense. Mechanisms of action, we know them from epilepsy. They line up perfectly to address a chronic debilitating disorder like schizophrenia. That is all of the preparatory work for controlled trials. We've got funding for 3 pilot trials, Australia, Ireland, and Stanford, that are taking place. They're going to be taking place. They don't all have their IRB approval in place yet, but they've all got funding. They are gung-ho about moving this forward. In my mind, that is the next step of this journey. If those trials are positive and show a benefit, the medical establishment will want a larger, multi-site, maybe even, but at least single site, but a larger, more comprehensive study. The family that I'm working with is prepared to fund a study in the millions of dollars for that purpose. But we first have to see, do we get a signal, a strong signal from the pilot trials? If we don't, do we need to modify what they were doing? Why didn't it work? God forbid we should have a Johns Hopkins outcome, the Johns Hopkins Alzheimer's outcome. We tried to recruit 60 patients and we could only get 10 to participate. That kind of literature really steers the entire medical establishment away from this therapy. You're proving to us that it's impossible for people to do, and you're supposed to be experts in it. And you were trying to do this study and you couldn't get it done. Well, that basically tells us that this is an impossible treatment, so there's no point. We don't care about science anymore. If it's not implementable with real human beings, it's not an effective strategy. So I'm hoping to move things forward. Thank you all.
Thank you very much, Chris. That was awesome.